It is my proud privilege to welcome you all for this second GS Kulkarni Oration and keynote address during this richly organized ASAMICON 23. The privilege simply gets bigger when I am here to introduce the speaker, and it is none other than the iconic Dr. Mangal Parihar, the man who actually needs no introduction, and the orthopedic surgeon whose words are like a gospel to many of us young and old in this auditorium. Having said that, I would be failing in my duties if I don't give a formal introduction of him to all of you. Dr. Mangal did his MBBS and MS Orthopedics from the University of Mumbai in 1984 and 1988 respectively, with flying colors as the university gold medalist. After his initial days of basic orthopedic training in registrarship in India as well as England, he never looked back ever since then and went on to excel in his field by doing a large number of fellowships and advanced courses wherein he learned the arts of arthroplasty, arthroscopy, trauma management and limb reconstruction using Ilizarov methodology from the most reputed centers and mentors of the times globally. To name a coveted few, he has done his fellowship in Ilizarov technique with Dr. Rod Bailey from 92 and 93 and visiting orthopedic fellowship in arthroplasty with Dr. C.S. Ranawat in New York. Dr. Mangal has more than 25 years of teaching experience as well as an equally rich experience of being an undergraduate and postgraduate university examiner. He has multiple textbook chapters and publications in peer-reviewed national and scientific journals. He has been in the board of reviewers of several reputed scientific journals. He has organized multiple courses as well as traveled far and across the country to preach the art of Ilizarov methodology and limb reconstruction. I was lucky to be his co-faculty in few of the courses. It would not be an exaggeration if I call Dr. Mangal Parihar teacher of teachers. He has been a willing mentor and has gladly accepted fellows for training along with provision of stipends and accommodation. The fact that his fellows are going great guns in the field of reconstructive orthopedics is a testimony to the fact that he has been a true torchbearer of orthopedic surgery as well as Assami India. Currently, he is consultant orthopedic surgeon at Mangal Anand Hospital, Mumbai, and honorary orthopedic surgeon with Grants Medical College and Sir J.J. Hospital Groups and Police Hospital in Mumbai. We all know of his keenness in computing and internet for medical education and record keeping. He has special interest in various types of computer-assisted 6-axis fixator systems and has been an instructor to the courses pertaining to nearly all of them. Dr. Mangal Parihar has gone on to design the indigenous 6-axis system, namely the DEFFix. So without any further ado, let me invite the mercurial Dr. Mangal Parihar, one of the most respected ambassadors of Ilizarov methodology in the world, to come on the stage and all the audience who is eagerly waiting to listen to his responsive journey to Ilizarov. Thank you.
Thank you, Ruta. I'm glad that there is a videographer here because I'm going to take this recording and show it to my wife and my children who don't believe that I am any good. So, to talk about essentially, how we started with Ilizarov and where we are going. Thank you, of course, to Asami India, ASAMICON, Ruta as the president, and GSK and his family, Milind, Sunil, who have been personal friends now for years, apart from our professional relationship. So it's not going to be all science. I think I want to be more of a storyteller. Some stories of GSK, some stories of how I started out. Those of you who know GSK, unfortunately he's not here today, but he's always in the first row, and even at this time, at this age, he would be taking notes, one of the first to get up and ask relevant questions. And I hope that, when we are at his age, we have that energy and enthusiasm to keep up with orthopedics. After I came back from my fellowship with Dror, Ilizarov was kind of catching up, and GSK right from the beginning always kind of treated me like sort of equal, never as someone junior. He's given me a lot of respect, recognition and encouragement in terms of my journey with Ilizarov. I remember 2001, I think it was, when he was standing for president, and we were doing a lot of workshops around the country as part and parcel of the what you need to do for meeting people to get elected. And we did a workshop in Agra. I think it was probably a Saturday, all-day workshop. And the next day, we were to catch a flight from Delhi, sometime in the afternoon. So once we finished the workshop, GSK asked the local organizers, "Arey, what else can we do over here?" So they said, you can, Taj Mahal he had already seen. He said, Bharatpur is there. But to see birds in Bharatpur, you have to get up early, I think 5 o'clock or so, to get to Bharatpur before sunrise. And I said, "Sir, 1 baje ka flight hai, aaram se idhar 12 baje niklenge." He said, no, we have come here, we should go and see. And that to me was a phenomenal experience. Early dawn, Bharatpur, GSK walking, madam I think was in the rickshaw. And if for those of you who've been to Bharatpur, on both sides, complete mist filled with birds. It's a beautiful sight. And that actually, when I saw that, I said, if he can do it, why can I not do it? And he kindled my love for nature and photography. So now, along with orthopedics, I love going to places, taking photographs, and this is certainly thanks to GSK in no small part. These are some pictures that we did at Corvette about a month back. And this was also Corvette, this was Kanha, I think, a couple of months back. So that's now part of my regular routine, just like workshops. The first time I heard about Ilizarov was at KEM Hospital when I was a senior resident. There was a surgeon from the US who had sat on the first row of Ilizarov's talk in New York and photographed all his slides. And then when he came back to KEM, he delivered almost a 1-hour lecture based on those slides. And that talk had all those pictures from Ilizarov's book, the humorous non-union with turning all over. And I'm sitting there as a post-MS registrar, and I said, wow, this is something that I need to learn. This is going to be the future of orthopedics. Those days there was no internet. The only thing that was available in KEM library at the time was something known as Silver Platter. Every 3 months there would be a CD delivered from PubMed, and on the computer you could search in the library. So I went to the computer, to Silver Platter, searched for Ilizarov, and the name that came up almost all the time was Dror Peli. So I said, I have to go and do a fellowship with them. So that set me on where I need to go to learn. But I was a resident, and you know how modest residents are. Residents always want to operate. So I knew about the Ilizarov and I wanted to do the Ilizarov method. So we decided, how can we do the Ilizarov? And the first thing that we did was with a modification of a AO fixator. So this was in '89. Patients used to come from interior of Maharashtra to Mumbai because interiors didn't have as good medical services as they did today, so couple of days they would take to reach, by which time this fragment was entirely dead. So we took it out, and as was the wont in those days, put a plate on, and this gap would then have been treated by bone grafting. But we had heard by then of bone transport, so we said we should try a bone transport. So we modified an aortubular fixator with a standard rod over there, but a threaded rod onto which these pins were fit. The level of ignorance is evidenced by the way that we have opened out the bone for the osteotomy. This is certainly not a corticotomy. And that bone was still, we were able to transport it, and you can see good regenerate in that. Also, the first real Ilizarov I did was before I went, when I was a post-MS registrar, as we used to call it. We got our hands on what's known as a Monticelli-Spinelli fixator. Monticelli and Spinelli were two Italian surgeons who had been to Kurgan and then developed their own kind of fixator. There was hardly any information about Ilizarov coming out in those days. So the gentleman on top is Mr. Kulkarni. He was a manufacturer of a company called Orthosis, who was concentrating kind of on external fixators. And below was my then boss, my PG guide and head of unit at the time, Dr. Shahane. So using that brochure, Kulkarni and me, we devised, we kind of judged, okay, what will be the sizes, etc. and made this fixator. We had very little knowledge. There was no tensioners available. We knew we had to tension the wires, so we tensioned the wires with what used to be, I don't know whether it's still available, a K-wire bow, Kirshner bow. You put it on K-wires for giving traction to younger children. Probably doesn't happen anymore because younger children also get operated on today. But in those days, traction was treatment. So, why I mentioned both of these is Kulkarni was very keen in terms of developing. And Dr. Shahane was, in those days, we had the honorary system. And the credit for Dr. Shahane is that when I said, okay, I want to do this, what he wanted was that you have read everything that is available. And he allowed me as a senior registrar, post-MS registrar, to do the surgery while at the same time standing behind me for 2 hours when he had no need to do it. Right? So that was the level of the Chhatro Chhaya that was provided by people of this generation. So that's the first one, which was a little bit of CTV. There was an article by a chap called Franz Grill from Austria, and we applied this and we got a good correction. There was only one ring above, one ring for the heel, one ring for the forefoot, and very weird sort of hinges. That's on the left is the pre-op, on the right where we've been able to straighten out. And the second case totally failed because of our ignorance. And so this was like for the Ilizarov, that was a 50-50. Then I went to the US, I learned Ilizarov and came back, started working in terms of my own practice and doing all kinds of workshops. And that was a time when anyone and everyone was doing Ilizarov for anything and everything, And that was one of the things which led to a certain little bit of the downfall. People burned their fingers with not applying the principles properly. I made good friends during this time when we used to have workshops all over the country, and one of the specific ones was Palakkad. And you see there Prasham Shah, who's a surgeon from Bombay, doesn't do Ilizarov anymore. But in those days, Ilizarov was practically unknown. So Palakkad had a special attraction, was that you could assist in the surgery itself. So a lot of people who are practicing Ilizarov now used to be there. You see Cherry here, who's also not able to be here. And that's the older Vasu. He's lost all his hair now, but he had a full head of hair at that time. So then I went ahead into deformity correction, malunions, development conditions, high tibial osteotomy, OA knee, HTO especially, with the Ilizarov, and more importantly, we developed the local version of the orthofix in terms of the unilateral, and I was using unilateral a fair bit even for things like deformity correction. And yesterday, those of you who were here in the workshop would have seen me talking about how you need to plan, etc. And that is not a case of, hathi ke daat dikhane ke alag aur karne ke alag. We always used to do planning. In the days of analog, the yellow paper you see is the film that you get on, which you get for the X-ray film. And we used to make various plans, like for you see for this particular patient, what if I do one osteotomy, what if I do two osteotomies, what if I vary the level of the osteotomy, then decide on one plan and then try to carry it out appropriately. So that was the most important. Multiple plans, decide, okay, this is what I think is right, and then try to achieve that in terms of the surgery. So even with a unilateral fixator like this, you could get a reasonably good correction of what seemed to be a difficult deformity. Ilizarov is great. There is nothing like the Ilizarov when the situation demands it. But for very many situations, internal fixation may work as well. The problem with internal fixation is the accuracy and the reproducibility. And that is why many of us, like for me, when I do an HTO, I still tend to use a fixator because I can get that absolutely right. But in many of the other situations, that may not be required. And so there, we use nails and plates, but still with the principles that we had learned because of Ilizarov. So we went on then to digital planning and internal fixation. Here's one of the early cases. What looks like a complex deformity, but if you sit and analyze it, draw a proximal axis, a middle axis, a distal axis, and then plan, okay, what am I going to do, step 1, step 2, step 3, you will realize that proximally, this one, the most proximal one we are going to leave, proximally I'm going to use a rule 1 of the osteotomy where we are doing only an angulation, and distally I'm going to use rule 2 because the cora is here and the osteotomy is going to be there. So I'm going to do angulation and translation. So in my mind I'm reasonably clear as to what I want to do. Now because this was digital, we could plan on it and simulate the correction also. You can do the same thing with paper. On digital it's just easier, right? So we made a plan that, okay, this is how we want to correct it. Then it comes down to following that plan. So you do proximal reaming, you do a proximal osteotomy where you take out a wedge as was dictated by the plan, do an osteotomy distally. Because this patient already had a nail, I will not be able to push the guide wire and the nail in the direction I want. So I entered from the distal using a drill bit, did the translation that is required, corrected the angulation and passed on that drill bit into the proximal fragment. Reaming in the distal femur is over a guide wire passed through the knee and then a nail passed from the top. So we made a plan, followed the plan, and what you see on the left is the plan that we made, and what you see on the right is the way that we executed the plan. So I always say you have to be your own worst critic, right? So see what you have done, analyze, okay, where did I go wrong, why did I go wrong, how can I be better next time. It's not a problem to make a mistake. You can always make a mistake. Don't make the same mistake again. So that's her post-op, her function, healed at 16 months, and then she had her foot also done. We are very comfortable with digital planning, but oblique planes or coronal and sagittal planes, that used to give us trouble. And I wanted ways that we can do 3D planning as well as templating. So we got in touch, or we were in touch with a bunch of guys from IIT to develop. They were already kind of developing some software on their own, which we were then able to guide with our inputs. So this was a patient where, one of the first cases where we had used that software. She had a varus deformity. She was a 21-year-old dentistry student, bowing of both legs, and she had pain mainly on the left. There was some pain on the right, but mainly on the left. Her need was, I need to get back to college. So I like to be accurate. So that accuracy was a need actually from me. Early weight bearing and getting back quickly was a need from her. And all of that translated to an acute correction with internal fixation. And I could not really use the Ilizarov in that situation. Now when we do planning for these cases, you may get digital planning, and that will show us that she has deformity in the femur as well as the tibia. You can see when she is walking there is a clear thrust. So this is a patient who needs very perfect correction, otherwise her loading on the inner side is going to continue. So she had a distal femur varus, you can see that 94.6, 81.8, and probably some element of internal rotation. So with this TAP plan, you can take 2D X-rays and convert it into a 3D model. Most important is you can also assess rotation out of that, and it gives you a way of compositely planning in all the planes for all deformity. So this is the bunch of people, Vikas and Amit Karade, the first two people on the left are the sort of main guys. And what they do is you take a X-ray, full length X-ray with a sort of specialized marker which gives it also 3D information, AP and lateral, without changing the position of the marker. So that's the X-ray with the markers, and that X-ray then automatically can generate a 3D film like this, which will give you all of the numbers that you normally require for deformity correction: LDFA, MPTA, LDTA, version, HKA. There is also anatomical parameters which I have not shown, that is what you've heard about, the PDFA, PPTA, all of those. So using this model, you get your numbers, but more importantly, you can also simulate the correction in 3D. So you can correct varus, valgus, procurvatum, recurvatum, all of it. And this then gives you the simulated post-operative correction. So the LDFA is 96, after your correction it is 87. Version, we have not changed over here. MPTA was 79, it becomes 87. So similarly, you can correct it and play with the numbers to see that yes, this is now giving me proper correction. It also tells you where is your osteotomy, what is the wedge that is to be removed, what is the angle that is going to be corrected, what is the distance of the osteotomy from the nearest joint. So similar to 2D, but this is done in 3D. So here you see a trauma CAD, which is the normal digital, and on the right side you see TAP plan, which is the 3D. So as you know, failure to plan is planning to fail. So every case that we do, whatever plans we have are always up on the wall. Okay, what is the angle that we are looking at? What is the correction that we need to do, etc. So in this particular situation, we planned for a closing wedge distal femur, a double level fibular osteotomy, a double level tibial osteotomy with an ETN, and the question was which one first. We decided to do the tibia first, okay, and then adjust for anything in the femur. So we mark the cora and the osteotomy based on the numbers that we have got from the software. We mark rotation. We are not planning to change the rotation, but so we mark the rotation by 2 KYs, which you can see are parallel to each other when you look at it end on. So at the end of surgery, these KYs should remain again parallel to each other. And then do your proximal entry using standard principles of Polar wires or Polar screws. Do the osteotomy at the appropriate level, correct the alignment, advance the guide wire, ream and insert the nail. And I have this concept of what I call Sasta Navigation, which I spoke about in the workshop, where you can actually measure angles on the image intensifier screen. The DFO was a standard DFO, routine closing wedge. You check the alignment and adjust it if required, and then finalize the fixation. The interesting thing is, all of these numbers you can check on the CR. Okay, so we wanted an osteotomy gap of 11 millimeters for an angular correction of 12 degrees. We wanted that osteotomy, proximal osteotomy of the tibia to be 102 millimeters. So we measure up. Of course, you will say, how do you know it's 102? It could be 101, it could be 106. Yes, it could be. But we are aiming for a certain number. The only error that comes in is by error of measurement, right? So all of these numbers come from the software. Then we can do this intraoperative alignment check. So I wanted that LDFA has to come to 87. So you use the alignment rod, and using that navigation which I showed you, I can measure I'm at 86.9. Using the same alignment rod MPTA, we are planning for 87, 86. LDTA 92, 93. That's pretty good accuracy for internal fixation. That's a post-operative X-ray, and that's a post-operative clinical picture. And the interesting thing is, we did the same 3D X-ray of her post-operatively. So we were able to get again computer-generated numbers of her post-operative limb. Okay, so that has given us all of these numbers, the LDFA, the MPTA, LDTA, etc. And you can see the 3D model obviously looks straight. So if you now compare the simulation numbers to the actual numbers that we got in the corrected limb, LDFA 87, 87, MPTA 87, 86, LDTA 92, 91. HK 176, 179. This is probably because the femur has, tipped over, the soft tissue component. But the idea is that this is a pretty accurate way of doing things. So that's her pre-op, that's her post-op, 2 months, 6 months, and you can now see that her leg is straight and the lateral thrust which she had has gone. So that's one of the biggest advantages of using a tool like this, is to correct this in an accurate fashion. And we can also use this for pre-constructing an Ilizarov frame for a patient like this, where normally with digital planning we would simulate the correction and then mark out where we want the correction to happen and where we want to put the rings, etc. So this can be done directly on the software, where the surgeon themselves, you don't need an engineer for this. This is on the screen on a browser. You can change it into various views. So that's an AP. This is done from a CT scan. This is not from an X-ray, because this is a juxta-articular deformity. But you can hide or reveal the other bones as you require them. There's a big advantage to being able to visually see how things are, and you can see all of these parameters that I was talking about, the numbers. So mechanical parameters, your MPTA, all of those. You can see the anatomic parameters also. So here we are concentrating on the tibia, so we are going to hide the femur. I can move from AP to lateral. You will notice there are axes over here, and you can move these axes depending on what is the angle that you think. Using this, you can move your cora and the osteotomy plane also. There are ways that you can link the osteotomy to the cora, or you can move it up or down. So you can do multiple iterations. You can play around with this deformity and then go to the correction part. This will show you what type of osteotomy. Open wedge, you can do an open wedge, closed wedge, first and the second osteotomy. You can change the inclination of the osteotomy and then go to correction and see how it looks in terms of correction. What are your numbers before and after correction? Most important, what is the length that is achieved? So all of these things are available directly to you on the screen, and you can play around with all of this. If you are happy with this correction, you can then choose how you want to correct this. You can choose this. You can choose internal fixation. You can choose external fixation. Various forms of internal and external fixation are there. So here you can see various forms: a nail, plate, a hexapod, or a simple Ilizarov. So we chose to have an Ilizarov. So on the corrected bone, you have the Ilizarov fixator put on. Your hinge is locked to the right place, and then you can change, of course. If you want to have it a little more lateral, you can have it so you have a lengthening hinge, etc. Generally, I prefer to have it right on the convex, and then you get the numbers for your pre-constructed frame. What should be the length of your rods? What should be the length of your motor? What should be the position of your rods? All of that is available from this software, and you can then make this frame, send it to autoclave. So that's the frame that was put on according to the plan that we had made in that particular case. That's the frame, that's the correction, and that is the final. The same thing for a patient who had a deformity in the tibia, who had to undergo a lengthening by a precise nail, but she had a valgus and a recurvatum deformity, right? So doing the same kind of planning, we created an external fixator kind of jig, where you can see one pin in already, the other pins are about to be put in. So we put in pins perpendicular to each particular fragment and then do the osteotomy, put the nail in. So now you can see the bone is straight on the AP as well as the lateral, and on the right side you see after all of the lengthening has been completed. So there is another example which I will give you in my talk for jigs later today. So finally, I want to leave you with two thoughts which I strongly believe in, that whatever it is that you enjoy in terms of orthopedics, this is something which Steve Jobs said. I don't know, I love Mac computers also, but not necessarily because of that. But Steve Jobs said your work is going to fill a large part of your life, and the only way to be truly satisfied is to do what you believe is great work. Only way to do great work is to love what you do. And if you haven't found it yet, keep looking. Don't settle for less than what is the best. And the other thing which I think as doctors is very important for us is people will forget what you said, people will forget what you did, but they will never forget how you made them feel. And that I think as a doctor is one of our prime responsibilities for our patients, to be kind to them. Thank you very much.